All right, so we're going to go over a quick wound care sheet, or it's not even wound care, it's just wound sheet. So you know all the terms that we're about to use, and we'll go into things like assessment and Braden scale, pressure ulcers, that kind of thing. Okay,
Yeah.
but this one's just kind of an overall. Let me make sure that you know the terms before we hit it. Okay.
Mm-hmm.
Okay, so when we're talking here about susceptible populations, these are people that are susceptible to skin issues. Okay,
Mm-hmm.
you know, the skin is our largest organ, right?
Mm-hmm.
And is our number one innate immune system, right?
Mm-hmm.
So the skin and the mucous membranes are our first barrier to any kind of infection. So that's why skincare in the hospital is so super important, because if it gets breached in any kind of way, then our immune system is breached and we have to kick into our secondary immune system.
Yeah,
Okay.
that's like the. Is that like is that the T
It's
cells?
T cell and B cell immunity.
Yeah,
Yeah.
yeah.
But those have to work a whole lot harder. And if you have a patient that's already in the hospital trying to fight other things, the last thing we want to do is to give their immune system one more hit.
Yeah,
Right.
yeah.
Okay. So let's look at our susceptible population. So anybody that is either too thin or too big. Okay.
Mm-hmm.
If they're very large, obviously that puts a lot of weight on their body, right? But
Mm-hmm.
also if they're emaciated, very, very thin, then their skin is usually very thin as well. And that
Mm-hmm.
can sometimes mean that they don't have the nutrients that they need in order for their skin to heal. Okay.
Oh, got it. Yeah.
Fluid volume deficit and fluid volume overload. So if you think about how our skin is supposed to be clean and dry. That's what we always want for skin to be, right?
Mm-hmm.
And it does
Mm-hmm.
need to be moisturized if
Mm-hmm.
there's not proper like humidity, right? But if you have fluid volume deficit and you're too dry, if your skin's very dry, it's going to make it, first of all, itchy. Okay. And a lot of, yes. And then they itch it and then it breaks that barrier.
Yeah.
Right. But then if they're in fluid volume overload, then they've got third space fluid. You know that from fluid electrolytes.
Yeah.
That
Yeah.
means their skin, though, is sitting in a layer of fluid.
Yeah.
If you think like anytime you sit in the bathtub for a period of time, your skin gets all wrinkly
Yeah,
and yes, and then it very easily tears. So patients,
yeah.
if they have third space fluid, so if they've got edema up their legs or anything like that, they're going to be at high risk of pressure ulcers because their skin is sitting in water. Yeah. 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 I know. All right. So any excess moistures, especially if they are incontinent, okay. If they're sweaty, so diaphoresis is a big one. Okay. So we need to keep them clean and dry. Okay. Our liver patients. Now we haven't done anything with liver yet, but you know, liver, it is responsible for getting rid of all of our waste products. So if the liver cannot do that, so if they have cirrhosis or hepatitis or the liver's broken in some kind of way, then they can't break down all those waste products, and all those waste products build up underneath the skin. So all liver patients itch horribly, and then when they itch so hard that it breaks the skin, and then under the skin is the waste products. So all those waste products are just in their open skin.
Wow.
It's very bad. Yes.
That
Yes.
ugly.
Yeah, like you can walk in the room of a
Can
liver
you
patient, you
tell?
can smell it.
You can?
Yeah.
Like the toxins
Yes.
and stuff?
Yes, it comes out of their breath. It turns their face brown. I mean, it's liver disease is bad
Is it
news.
more they turn, so it's not yellow?
No, they can turn yellow too, but their
Okay.
face turns something, it's a brown color. It's
Oh.
called uremic facies. So uric acid will build up underneath here. It'll also build up in their breath. I mean, and when they speak, it like it's an unmistakable odor. Like you can tell it's a liver patient. Dying from liver failure is one of the worst deaths I think I've ever seen, because they ooze blood from everywhere, because your liver makes all your clotting factors, it makes platelets, and it makes vitamin K. So when you're in liver failure, you can't clot your blood at all. So they're dripping out the nose, and I've seen them drip out the eyes and out of the rectum, and they're just like oozing blood and waste. It's it's ugly. So that's why you, especially when you see our liver patients, they're at high risk of skin breakdown. Okay. Anybody
Yeah.
that's immunocompromised, of course,
Yeah.
right? That would be our cancer patients, chemo.
Mm-hmm.
Eczema or psoriasis, those are skin conditions. They scratch, and when they
Yes.
scratch, yeah, they're going to break the skin.
Right.
Any kind of chronic illness. I mean, this could literally be,
Like diabetes.
yes, because they don't get good blood flow and they
Yeah.
get ulcers, you know, any kind of chronic illness. And then chronic illnesses also don't give you the immunity you need to fight off any kind of infection should your barriers be broken. Okay.
You don't. Yeah, so it's going to take longer.
Oh, yes, much longer. Yeah. And a lot of times they'll get very, very infected. And because, especially with diabetes, there's tons of sugar in their blood. So when they get a break in the skin, bacteria love sugar. So they just go and eat in those wounds. And then they're very, very poor healing because they don't have good blood flow, especially to their legs. Okay. And then diarrhea is another one that will bust open the skin. Okay. So
Yeah.
any prolonged diarrhea can break open the skin. And in babies and even in elderly, even
Like
one
diaper?
episode of diarrhea. Well, it doesn't even have to be diaper, right? I mean, they could go like if they have really bad diarrhea and it
Yeah.
hits their very thin skin of an elderly patient,
Yeah.
or babies, yes, But even then, like their skin is also very fragile. It's not as thin, but it's just more fragile because nothing has touched it, you know?
Yeah.
And then immobility is a big one because that's pressure ulcers, right? Yeah. All right.
I saw a lot of that in the nursing home.
It's very sad in the nursing because they don't move them like they should. But I don't want to blame it on the nurses either because was it you that came in here and said that you were at the nursing home? There was like 20 something patients per one nurse or something.
Week, it was like 15, and these were people that were only there like supposed to be short term. It was awful. The stuff I saw, it was awful. I mean, the wounds I saw were just so bad. I mean, one guy was missing from the knee down, and then the other leg was he had lost his foot. And then we saw a woman. I saw colostomy bag changes. I saw that.
Those can get really emaciated too. Yeah, it's
I
ugly. I know it's so sad, and that's why I don't think I understand they may not have as many meds or whatever, but that requires a high level of nursing care, and you can't give that many patients to a nurse and expect competent care.
The thing is, the nurses in this facility, they're
Med pushers?
they're LVNs.
Oh, I see. I see.
And I guess maybe that's common.
Yeah, it's pretty common because they don't want to pay them as much, right? And then they rely on the CNAs and things to do the turning and that kind of stuff.
Yeah, which they aren't.
But there's even less CNAs. Yeah. Yeah. Because they have to do all the toileting and all of that. And sometimes that takes a long time for one patient. If you've got like 30 patients on one unit, like
it's understaffed.
it is. It
That's
is.
what made me. I left last week just
Feeling kind of crummy. Yeah.
Yeah, I felt sad.
Yeah, I know. It is really depressing.
Yeah.
All right, different types of wounds. So there are intentional wounds. That's like, hey, we meant to do this, right? We had to cut you open because you had a broken bone, right? Unintentional, obviously trauma or something like that. Okay. Open, broken skin, closed, it's closed skin. And fractures are like that too. So if they say like you have an open or a compound fracture, those two words mean that it broke through the skin. The broken bone broke through the skin. A closed fracture would mean that there's a fracture inside, but you know the skin is closed over it. The bone's poking out. It's also called compound fracture. Okay. Yeah, MSK for some reason. That's the only thing in nursing that grosses me out. Broken bones. Because I don't like the noise. Because when I was young, I broke my arm. I broke both of them at the same time because I got like a massive scar. But I heard it break. And so I think after that, and it made me sick. So I was like about to vomit, right? Yes. And so now I think when I see stuff like that, you've seen those like YouTube videos or TikTok or something where it's like a soccer player that goes and kicks and his leg breaks. For some reason, I can't do that. Okay. Anyway. Can't do it. I don't know. The MSK grosses me out. All right. Wound closure. This is often on exams. So how do we close wounds? Primary versus secondary intention. So primary means it's usually in some kind of line, and I can either staple it or suture it together. I can pull the edges together and staple it. Okay, or suture it. A secondary intention is usually more of like a gaping wound or like a tear, and I cannot pull the sides together. But sometimes even with a knife, I can cut it. Maybe a gunshot wound or a stab wound, but most of the time, if it's secondary intention, it's usually a pressure ulcer. They're so large that like I can't pull the two edges together, so I have to let them heal kind of open layer by layer by layer because I can't pull the edges together. Okay, so yes, and much higher risk of infection because you can't close it, right? But there are some wounds too that we could close by primary intention, but we choose not to. Like my niece, she's 4, and I forget what holiday it was. It was really last year. So she was we're at one of my relatives and they have a dog, but the dog's like not used to being around kids. And she had dropped a hot dog and she went to grab the hot dog and the dog went for it at the same time. And he like just shredded her poor little fingers. So she had a massive cut right here. Now it could have very easily been sutured, but anytime there's a dog bite, there's so much infection in dogs' mouth that they don't usually close those. So they just pressure closed it, like basically just put a pressure dressing on it, and then just kept watching it. But they let it heal by secondary intention, which closes from the bottom up, and it was left open just because they didn't want to suture in bacteria, if that makes sense. So primary just means I can suture it, I can staple it, and I closed it. Secondary means I have to leave it open for whatever reason, or I couldn't close it, or I needed to leave it open. No, you need to keep that one you need to keep dry. Okay. That's why I was getting confused on. Like some stuff most of the time, if the wound is dry, you wet it. And if the wound is wet, you dry it. However, on a cut, the cuts won't heal if they're wet. Yeah. Right. But pressure ulcers, a lot of times, if it is very, very dry, because they can crack open and stuff, you do a wet to dry dressing. Yeah. Yeah. So it depends on the type of wound and kind of
Okay.
what it looks like. All right,
Okay.
phases of wound healing. I'm going to go through these quickly. I don't know if they'll test on them or not, but you can kind of get the basics. And now that you
Oh,
understand fluid and electrolytes, this should make
yeah,
sense to you.
yeah, the hemostasis
Yes. So
and
that's where your body says something is wrong and it brings a bunch of stuff to the area, right?
like
Platelets, white blood
red blood cells,
cells, leukocytes, all of that.
the
And it's going to form an
inflammatory.
exudate, the
Oh,
inflammatory mediators and
okay.
markers.
So
Mhm.
the performer next to it.
Right.
Inflammatory is when all the phagocytes come in, right?
Yes. So inflammatory is when a huge amount of fluid comes in. Now in hemostasis, the first cell that always comes out, or the first cells that always come out, it's platelets.
Oh, it's
Because your
platelets.
body, it always
Oh, for the
knows, and
body.
it's smart. Yes, it knows that you will bleed to death faster than you would die of an infection. So platelets always come out first, just saying like, hey, just in case it's a cut or something, you have
Oh,
platelets here if you need it. So that's the hemostasis, as it brings blood flow to the area, and you'll immediately have like something coming out, right? Like let's say
yeah.
there's a gunshot wound, right? Immediately blood's going to come out. That is
Yeah,
exudate, right?
yeah.
And then you go into
So
inflammatory.
exudate can mean like any
Mhm.
like thing
Yes,
or
there's lots of them. I think I cover it somewhere else. All the
okay.
different types of exudate. It's on here somewhere.
Okay.
And then in inflammatory, that's when it gets red and swollen and painful because that's all third space fluid,
Yeah.
right? Because your body says something is wrong, and now it tries to get all of the white blood cells to the area that is injured. Okay, so you will see erythema, which means redness. You will see edema, which means swelling. And then you'll see heat because you vasodilated in that area trying to get blood flow there, right? Remember the inflammatory video? You probably didn't fluid electrolytes. It's on the YouTube channel where it says something is wrong and you vasodilate and it brings a lot of stuff to the area.
Okay.
And then that's what brings the heat. Okay. And then fever comes with that,
Yeah.
high white blood cells because your body knows something's wrong.
Mm-hmm.
And then the proliferation phase, that's when it's going to start rebuilding. Okay. So there's been some kind of injury. So it has to rebuild layer by layer back your skin and your collagen and all of that. So that's where you'll see fibroblasts. Okay. To blast means to build.
Granulation tissue. I
Mm-hmm.
remember her saying, yeah.
Yeah, so granulation tissue is a red healing tissue. Remember, your body always over responds, right? Like, for instance, if you do break a bone, right? Your body doesn't just make that new bone, it over makes new bone, and then your body will have to shave off the excess new bone.
Oh.
When your body is healing tissue, it over heals tissue, and then it
Oh.
kind of sloughs off. So that's a
Okay.
granulation tissue. You know what it looks like?
Mm-mm.
Okay, let me show you what it looks like. Because if you don't know what it looks like, you might think it's an infection because it's pretty impressive. It is very vascular, okay, very red, but
So that's
it's
building new
healing tissue. Hmm.
That's new.
So don't slough that off. Don't mess with that, okay?
Okay, so
Because
it will be
that's
granular.
healing, but it doesn't look like that. Yeah, it's impressive.
Oh,
So that is actually
wow.
granulation tissue. That's healing tissue. It's very vascular, so it's bringing a lot of blood flow to the area to help heal. Okay,
Whoa.
so that's what happens in proliferation. It starts to rebuild layer by layer.
Okay.
And then in maturation, it has to form scar tissue in its place. So in maturation, that's where it forms scar tissue, and then the wound healing is complete. Well, the granulation tissue will kind of slough off on its own when it's brought enough tissue and it's healed. Okay. So that's the phases of wound healing and kind of what we're looking for. All right.
Okay.
And let's see. Make sure it is your nursing responsibility to perform a full skin assessment every single shift, which basically means it's a head to toe, but not the head to toe that you guys do. That one's too detailed. We're just looking at skin. So you want to make sure you roll the patient over and look at the back. Especially in the nursing home because they can get pressure ulcers back here that you don't see because it's covered because of their hair, you know. And they also, there's all kinds of stuff that can happen to their hair too and to their scalp. There's lice and there's all kinds of stuff if they're not taken care of properly. And then a lot of people fail to turn them over on their back, right? They'll just look at me like, oh no, you look good. No, the back is where most of the injuries occur. Sacrum, back of the heel, yes, because you're laying on it. And a lot of people, especially if it's an overweight patient and they don't have people to help you, they'll just kind of like peek underneath them. You really need to roll them fully to each side. Yes, which makes it more difficult, of course. And sometimes it's hard to see too, like, and I don't mean to be insensitive, but like under some of like the rolls of fat, it's sometimes hard to tell underneath there because there's a lot of yeast infections and stuff that can hide in those folds. You got to dig up in there. Yeah, you do because you could miss a lot of things. Like we've seen some patients that were either in the nursing home or in the geriatric unit, and they just have a fever and we can't figure out what it's from. And then we found out like nobody ever actually like looked or on their whole skin. They're getting a workup and everything, right? But there was like a massive pressure ulcer developed around the rectum and nobody even looked. And that can be deadly because if you have an ulcer that's open right there where poop comes out, like that can make you septic in no time. Oh yeah. Yeah, it's really rough. All right. Next, What affects wound healing? All right, so things that could affect the wound, like if they do happen to get a wound in the hospital, what are some things that would affect that, right? Too much pressure, that's pressure ulcers, right?
Yeah.
And then there's two different words you need to know. One of them is desiccation. Oh, yeah.
Oh,
Okay.
okay.
So desiccation is when the wound is too dry. If the wound is too dry, then it can crack open and not enough blood flow can get to that area, right? Maceration is if it's too moist, if it's too wet. And any wounds that are too wet can't heal because basically like you're sitting in a bathtub trying to heal a wound, right? Any repeated trauma to the same area, that's a given. Edema can affect wound healing because remember your skin is sitting in fluid and water. Yeah. If they get an infection in the wound, that's going to be a lot more difficult for it to heal because you have to treat the infection and the wound at the same time. Okay. Clotting. So because your body responds by sending platelets and things like that to the area, they can get massive blood clots in wounds. If there's a clot there, then that doesn't promote blood flow. It stops the blood flow. So you want to make sure that you really do a thorough assessment of the wound. Okay. Necrosis, that's dead tissue that has to be taken out because it's basically like trying to heal a patient with a dead body right next to them. Like that's gross. You can't do that. So you have to get all of that necrotic or dead tissue. And usually we do it by surgery because it's very painful because you have to cut it out. Right.
So is it really, you can't do it?
I mean, there are other ways to do it. I'm not going to say that's not true. Like at Shriners, they will get off the necrotic tissue, but the way that they do it is horrifying. So on a certain day at Shriners, it's called tub day. Okay. And I've worked in PD, so this is the PD. And on tub day, all the kids know like it's tub day. Okay. And so they medicate with them as high of a dose of morphine as they can, but it doesn't matter. It hurts that bad. Then they wheel them down. And you can hear them screaming all the way down the hallway because they know what happens. Then they put them in a bathtub full of something called Burrows solution. It's like an iodine kind of fish solution. And they have to get off all that necrotic or dead tissue. Do you know what a Brillo pad is?
Yes.
They used to watch. That's what they do, and they have to slough it off until it starts bleeding. So they're sitting in a bathtub like of skin and blood, and it's excruciatingly painful. So you can hear them screaming all the way down the hall. It's just a horrifying. I didn't want to be there anymore. So that one. It has to be taken off though, or it will never heal those wounds. So a lot of times they do like to do it in surgery, but like those really debridement. Yeah. Yes, they'll debride. Now surgically it would be nicer to do that, but you can't put these kids in surgery every week, right? I mean, these are kids that were significantly burned, so okay. Older adults, of course, they have a decreased immune system, so their healing is decreased. Okay. Any lack of blood flow, because in the blood comes all of your healing mediators, white blood cells, things like that. So that would be like patients who are very heavy smokers, patients with peripheral artery disease because they don't get blood flow to their legs. Anybody that's not getting proper blood flow, diabetic patients don't get good blood flow, right? Okay. Patients with poor nutrition will not heal correctly. If you look at this right here, I put it in red and I put a heart, right? I mean, a star. Vitamin A, vitamin C, and zinc are required. You can't heal correctly. Those are required in order to heal wounds. Okay. That's why, like, when, babies have a diaper rash, we put zinc oxide on it, that little diaper rash ointment, right? Because it heals that area. Yep. All right. And then chronic corticosteroid use, because corticosteroids are synthetic stress hormones. So you're basically giving the patient constant stress if they're on corticosteroids. Okay.
It's just more stress.
Yes. Now, short term, a stress response is good because our stress response is healthy short term, right? It's meant to help us deal with stress. But long term stress response, we know that causes high blood pressure and hyperglycemia and all of that, right? So, and it can also decrease their immune system. So, if they're on chronic corticosteroids, which would be over 6 weeks of therapy, okay? Any radiation to an area because you're burning. Radiation is burning an area, right? Okay. And then if they're immunosuppressed, that was a given. Okay. All right, let's talk quickly about right here, wound complications. Okay. So obviously they can get an infection in the wound that would cause pain, fever, and now you know what exudate is, right? Some kind of junky.
It's not just, for some reason I was thinking exudate was like.
Pus. Yeah.
But it is.
It is one type of exudate.
But
Sure.
that's when I thought of exudate, that's why I was thinking something just sort of like sticky and.
Well, that's true. It is anything that is leaking. So it's just leaky fluid. Okay. It can literally be anything. Okay. White blood cells will come out, and then it decreases the healing because your body is more working on fighting the infection than it is on rebuilding your skin. Okay. A hemorrhage can happen with wounds, obviously, if they're very deep, or you could also get a hematoma, which is a collection of blood that is clotted.
Hematoma is a collection of blood that's just clotted.
that clotted. And then dehiscence and evisceration, ATI and HESI really like to test on these.
That's
Okay.
one, okay, where one is like totally removed and one's
Sure. So dehiscence is where, like, this is usually if you've had abdominal surgery and they
okay.
like staple you back together.
Yeah.
But because you are either very overweight or you put a lot of pressure on that wound, either from coughing, sneezing, vomiting, pushing to poop, those are things that increase our abdominal pressure and the wound will bust open. So
Okay.
dehiscence just means it busted open. Evisceration, because visceral means organs, evisceration means it busted open and your
The
abdominal organs
organs
came out of the
are
hole. Okay, I know I don't like that either. So if that's the case, well, first of all, if they've had
wouldn't that be
abdominal
that
surgery,
would be an
it's an
emergency.
emergency, yes. You need to put them in low Fowlers after abdominal surgery because if they're too high up, that puts pressure. And then if they're flat, that puts pressure. So you need them in low Fowlers. And then if you do have that happen, okay, you immediately are going to get a giant ass towel that is soaked in sterile saline, okay? You're supposed to be, and put it over it just to keep your organs moist. And then call the physician immediately because obviously they're going to have to go back into surgery to like put all the organs back and sew them back on in. It's common. Yeah. So there is not something called this. I'm going to be very clear. But here we made up a term called pressure precautions. Okay. And pressure precautions are something we put anybody on who cannot have excess pressure anywhere in the body. And that would be things that would, anytime you like that increases pressure. Sneezing, sometimes like sneezing, vomiting. So in pressure precautions, which would be patients that have had abdominal surgery because we don't want it to bust open, we do not want them to cough, sneeze, vomit, push to poop, bend over, strain.
So are they like all hooked up to tubes where they don't have to like do any of that stuff?
Nope.
They
So good luck,
okay.
nurse. Yeah. So if they have vomiting, I'm going to call for an antiemetic, right? Which hopefully they'll have an order for that anyway. If they've just had surgery, chances are they feel pretty pukey, right?
Yeah.
But if the patient develops a cough or if they're sneezing a lot, then I would call to get something to fix that, right? But I would also advocate for stool softeners to make sure they're not pushing to poop, right?
Yeah.
But then even just obese patients are at high risk, even if they don't push, just because there's so much pressure on the abdomen. So it's just something you got to be looking out for and something you got to be careful of and something they always test on. Okay. All right. And then fistula. A fistula is an abnormal opening between two things. It's a tunnel. Fistula. Fistula.
Oh, yeah.
So it's a tunnel. Your body is insane and it will always try to find a way out. Okay. So I'm going to tell you a very personal story. Okay. My daughter, when she was born, she had an imperforate anus. So she did not have a hole in her bottom. Okay. And so when that happens, obviously there's no way for them to poop. So they have to get an ostomy the very first day they're born. So she went and got an ostomy, but because your body, she was brand new, right? And her body didn't get the message that there's a hole right there. It started creating its own holes. And this happens a lot in abdominal surgeries. Okay. Like after C-sections or any abdominal surgeries, if you got an ostomy, if you had a bowel obstruction, anything where your body thinks there's not a way for poop to come out, it panics and it is going to make its own hole. Okay. So she was a little bitty baby, but she had a double barrel ostomy right here. Okay. She did dehisce between the two ostomies. So we ended up in NICU for 30 days because it completely opened up and you could look in. This is my daughter, the little one. Yeah. No, she was my second baby, but, so she dehisced, but then, because her body thought there's no way to poop, right? It started making all of these tunnels inside, but I didn't know because I couldn't see it with my eyes, right?
So your body just internally is making
it will make fistulas. Yes, it just does that. And so what I noticed was when I was changing her ostomy, I kept like wiping her like belly because you have to clean it and put skin barrier and all that, And so I kept doing that. It was still wet and still wet. I'm like, where is this fluid coming from? But it had made a fistula inside her her urethra to her belly button because she was brand new, so she still had like the little belly button stump. And so she started peeing out of like urine was coming out of that belly button. And so then we found out there was tunnels all in there because your body doesn't know, but it will always trying to find a way out.
How do they, I mean, in a newborn,
Uh-huh.
how do they can't do X-ray? What do they do?
To find out she had a fistula?
Yeah.
Oh, sure. So she was going in for surgery anyway. So they just started sticking like tubes in like the holes that she had on the outside to find out where they went. And so they were like going all crazy inside her abdomen. But there was also a lady I saw on TikTok. I know it was super awful. She had like 5 surgeries before she was born. Anyway, but there's a lady I saw on TikTok and she said that when she was a baby, she had a G tube. Okay. Did we talk about G tubes? Have we talked about that? Or do you know what that is? Little gastric tube for feeding. It's right here in the belly.
I saw it in one of the patients.
Okay. So she had one of those when she was a baby. Well, a peg tube and a G tube are different. G tube is put in surgically, and a peg tube is put in like at the bedside with localized sedation or localized anesthetic. Okay, but they're the
Oh,
basic same concept, right? So
okay.
she had that when she was little. She didn't have it anymore, right?
Yeah.
And then she said she started having this weird abdominal pain after she had her baby. I watched her whole series because I wanted to find out what happened to her. And then she noticed like there was like a tiny little abscess on her belly. And so she's like, all this fluid just started coming out of it. And they couldn't figure out what it was because it wasn't just pus, like it was like a lot of fluid. And she said it was burning and hurting very, very badly. So she went to all these doctors and they couldn't figure out what it was. But where the scar tissue was, long story short, where the scar tissue was in her stomach from where they had done the G tube had formed a fistula to the outside of her body and she was leaking out stomach acid. And that's why it was so painful. So your
So she
body can
was
just it
leaking out stomach acid.
yes, stomach acid right into her abdomen.
Oh, so that hurt hormones.
Oh, I can't even imagine. I can't even imagine. So she like I watched her whole like 3 year journey of trying to figure this whole thing out.
How is that?
But that's what a fistula is. It's an abnormal opening between two things, and your body can do that all inside
So
without
it's
you
all
even knowing
inside. So
it.
it's like a, would you call it a tunnel
Yes,
kind
it's
of?
a tunnel.
You would call it a
Yeah,
tunnel.
and
Okay.
sometimes the fistulas can get infected depending on what your condition is. So, like when patients have Crohn's disease or ulcerative colitis, they can form all kind of fistulas because there's so much swelling in there. And then because it's ulcerated, right, and there's poop going through there, you can get secondary abscesses in the tunnels.
So what did is the goal to get rid of the tunnels, to close
Yes,
them,
we'll close the
or
tunnels.
to close
Yes,
them? Okay.
yes, but
Okay.
sometimes that's very hard to do, right? Depending on where it
Yeah.
goes, and then you've got holes everywhere, so you gotta
Oh
fix
my
it. I know
gosh.
it's a mess. All right, we're going to go right underneath that to just basics of wound care. Remember when you're taking off old dressings because they're saturated with all kinds of junk, that's clean technique. Okay, so clean
Yeah.
gloves, what. Okay. When you are cleaning wounds and replacing the dressing, that is sterile
Sterile.
technique because you're putting on new things. So you
Mm-hmm.
have to switch gloves halfway through.
Okay.
Okay.
I was watching some stuff on ATI. Do you find
Mhm.
ATI to be
I think it's cool. I mean, I think the videos are nice. They at least give you a nice review. It depends on
yeah.
what kind of style you like.
Yeah. Yeah.
Some people, it's not for
I
everybody.
mean, it's like I'm between that and corresponding because we have to do some required
Hmm.
assessments, and I just think ATI explains things maybe a little better at
Yes, they're
times.
very by the book, which I think is helpful, especially in these courses. Once you get in higher level courses, it may not be as exciting for
Okay.
you, but I think it's great for foundational. All right, so cleaning when sterile. Oh, this is another thing I like to test on. If a patient has a wound drain, which we're going to cover in great detail later,
Yes,
you
that.
have to attach it to their gown, okay, especially if they're ambulating.
Wait a
But
second. So if they have a drain, you
mhm,
attach the drain.
to their gown, so it can't get pulled, basically.
Okay.
Okay.
So is that like those because we saw somebody that had just had I think colon surgery and she had one of
Mhm.
those little bulbs.
Yeah. So that's
Is
a
that
JP.
considered the
That's
drain?
drain. That's a type
That
of drain.
bulb is the drain.
Yes.
Okay.
So you'll attach that. Well, the tube is the drain. The whole thing is the drain, right?
Yeah,
But
because
you're
there
going to
was a
attach it
tube.
somehow. So you don't want it to hang off the patient because it could pull off the patient, right?
Yeah.
So you're going to attach it to their gown so that they can ambulate, but make sure every bag, and this is not just wound care, this is everything in nursing school, has to be below the level of whatever you're draining. Otherwise, it will not drain,
Yeah. Yeah. You need
right?
gravity.
Yes. So like Foley bags need to be below, chest tubes need to be below, everything needs to be below what you're draining so it can drain.
Yeah.
Okay.
Yeah.
All right. If you are telling a patient to use heat on their skin, like heat therapy or whatever, 20 to 30 minutes max because it can burn your patient, right? I would do even less in patients that don't feel as well. Like they can't feel their legs as well, like diabetic patients, if they have neuropathies, that's a tingling and the numbing of the
Do they use the
extremities.
heat just to get the blood
Yeah.
flowing? Is
You know,
that
like if you have like shoulder pain,
yeah.
like your back hurts, you put
Yeah.
heat on it,
Yeah. To
so it
relax. Yeah.
dilates, right? And it brings a bunch of inflammatory mediators to help you.
Yeah.
So that's
Yeah.
how heat can, yes, heat will relax the muscles. Cold decreases inflammation because it vasoconstricts.
Yeah.
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 All right. Let's see. Irrigating wounds. Just real quick cheat sheet here. If you're going to irrigate a wound, which where you pull up, stuff in a syringe and to clean it out,
Yeah.
okay, it is sterile, obviously, because you're going all up in a wound, okay? The tip of the syringe should be 1 inch above the wound. You don't want the syringe to hit the wound.
What?
The tip of the syringe,
Oh,
1 inch above the wound. You don't want to
okay.
put
You
it
don't want
actually,
the tip of the
yeah,
syringe touching
yeah.
the wound.
And make
Okay.
sure you warm it first or it's going to hurt like hell.
Okay.
Right? So just there is a warmer, we don't use a microwave in nursing school for anything.
Yeah.
Okay. But warm the solution first, at least to room temperature, because cold solution in a wound would really hurt. Usually we use normal saline or there's something called Burrow solution. And Burrow solution is usually what we use for burns patients. Okay. But they're both cleaning solutions. If there's severe pain or if the wound starts bleeding when you're irrigating it, you need to stop and figure out what the heck is going on and then notify the doctor. I mean, some discomfort may be okay, but if they're screaming in pain when it's probably infected, you know?
So that's like when you
So I would
stop.
stop and be like, that's really abnormal pain level, and then notify the doctor. Okay. You understand the basics of wounds. All right. So when we are debriding a wound, what does that mean?
Getting rid of the dead skin.
We're getting rid of dead skin and tissue because it can get infected and it can prevent new skin from forming because there's dead skin right there, right? There are 3 different ways that we can help to debride skin. Okay. There is an autolytic. Auto means self. Okay. And lytic means, or lyse means to kill. If there's a cell that's being lysed, or if I think of Lysol, we're trying to kill all the bacteria, right? So autolytic is, autolytic debridement is when we let their body do the natural debridement. So these would be patients, we would only let them do that if they were healthy, young, immune system intact patients. I'm like, hey, let's let your body kind of do its thing. Okay. So that's autolytic. It is self-healing. We put a dressing over it and be like, let's let your body do its thing because your body knows how to heal. Right. Okay. But if they had a lot of comorbidities and they were very sickly, obviously their body's not going to do it. So I wouldn't choose that.
Something like that.
Mm-hmm.
How would you leave that open, or would you close it?
You would just put a dressing on it, like a transparent dressing, so I can still see it. But I don't want it open to getting rubbed by your sheets and all of that, right? So that'd be like Tegaderm? Yeah, you can use Tegaderm, but Tegaderm's hard to stick. That's the only problem. That's the only thing I don't like about Tegaderm. It just doesn't stick very good. All right, enzymatic. So there are different enzymes that we can actually put inside the wound that mimic your body's enzymes that will help to eat away, kind of like, what macrophages are? Where macrophages are the cells that are inside your body that eat. Yes, or phagocytes. Yeah. So there are some enzymes that actually can be poured in there that will give your body a like pseudo enzyme. So you can eat away the dead. Yes, which is, it's better for your body to still do it, right, than for us to actually go and cut through it. I mean, we will do it, right? And that is called mechanical debridement. So if like your body can't do it, we don't think that you're healthy enough for the enzymes either, then we either will irrigate it. So we flush it with water. If it's very easily, I mean, I would have to slough off real easy to irrigate with water, right? We can do a lavage. So a lavage is a little more aggressive than irrigation. Okay. We can actually cut it out. Okay. So, and they can cut it out. They can do a debridement at the bedside with like lots of morphine. Okay.
I was just saying,
but if it's an extensive area or we're going to have to go very deep, then they would actually put you into surgery and knock you out and do a full surgical debridement. And they can also, at the same time as the debridement, they can do skin grafts if they need to. So if you've lost a large area and there's going to be a huge like hole in your leg or something, they can put skin grafts in. But they cannot put skin grafts on dead tissue, right? Because it won't heal for the dead tissue. Okay. All right. When you are changing a dressing, all right. So remember, when you're taking off the old one, it is what kind of technique? Clean technique. And when you're applying the new stuff, it is sterile. All right. So you want to give them analgesics about 30 to 45 minutes before you start the dressing change. Okay. Because it's probably going to hurt when you're digging around in there and cleaning it. Right. Make sure you wash your hands, of course. You're always going to pick good hand washing. If they ever give you that as an option, that is your choice. That is your choice.
That was one mistake I made with one question. I thought about it. It was, and I didn't pick hand hygiene.
Always pick it. 100% of the time, it will be for all of nursing school forever. Okay. And then you use standard precautions, which is basically like, wash your hands and use alcohol-based rubs as long as your hands aren't soiled. And what standard precautions are. Okay. And then clean technique to remove the old dressing, sterile technique to clean and redress. We talked about that. If you are going to clean a wound, it can only be cleaned with normal saline. We no longer clean with hydrogen peroxide. It is too abrasive and it will completely destroy the wound bed. Okay. Now we used to do this all growing up, right? If it bubbles, it means it's working. Now it was kind of eating away your wound. Okay. I cannot even I don't even know what to say about that. So if we're going to clean something, sometimes they'll clean it. Oh my God, please do. Cause I am deceased on this one. Normal saline is good to clean it cause it is like salt water, right? Which cleans out things. Okay. Sometimes they'll use sterile water, but the salt is good to clean out wounds. Okay. You are going to dry around the wound, not inside the wound, but you want the skin around it dry. Otherwise you can't stick tape to it, right? Nothing's going to stick.
So just dry. Okay.
So when you're cleaning it out, it's going to be all wet, right? which it's fine to keep that in the wound, but around the wound you have to dry it with a sterile
So
gauze
that-
pad
so
so you can actually tape it. Yeah.
Yeah.
Anytime you are applying creams or antibiotics to the area, make sure you wear gloves, which I'm sure you would anyway, not for infection purposes, but whatever is on your skin can get inside of you as well, right? So if the cream is touching your hands, you can get that cream absorbed into your body, right? Apply the dressing and secure it. And I think we talked about a couple different dressings. I won't go into a little bit more. All right. You are always going to clean from the inside to the outside because even though it's a nasty, gross wound, it's cleaner than the rest of your skin. Okay.
Right?
Yeah.
Really?
Yes, and this is always on exams.
I
I know. I thought that in nursing school too. I was like, they got this backwards. But because your wound is sterile, it's supposed to have never touched bacteria. The rest of our skin has staph and strep and all kinds of stuff all over it all the time. We have our normal flora and all of that. Inside this wound has been treated like a pretty princess, right? Like nobody has touched it, like, right? And they only touch it with sterile gloves. So it is the sterile part. Yes, your skin is dirty.
Thank you for saying
Does that make sense?
Yes,
Okay.
Yes.
Yep.
Yes.
All right.
Thank you. Yeah.
So always going to go from inside to outside, no matter. And I showed you what it looks like with a straight wound, like if you're going down straight or if you're going in a circle, and I'll talk about that in just a second. Clean the wound at least 2 inches beyond the wound margins. Okay. So if your wound looks like this and you want, or you're using straight down and you have to use a new cotton ball or whatever it is for every stripe. Okay. So you start with the middle because this is the wound is considered sterile, right? So that's your cleanest one. So swipe down, discard. Number 2, swipe down, discard. Number 3, swipe down, discard. And then you're going to go out because this is your dirtiest and the wound is the most sterile. I know, it's wild. And then if it's a circle, like a complete circle wound that you are doing in a circular motion, right? You start at the wound's edge and you do 1 swipe, go around once, toss it. Number 2, go around, toss it. Number 3, go around. And you keep going until you've gone at least 2 inches around the wound bed. Does that make sense?
Yes.
Okay. All right, tips. Okay. You want to make sure you use a skin protectant around the wound. It should not touch the wound because it burns like all holy hell. And you can only apply a skin protectant on intact skin.
So that would be like some sort of ointment or gel?
No, it comes as a little packet. I actually have some. Hold on 1 second. I'll show you what it looks like. Okay. So I grabbed a couple of these things so you could actually see. So this one is the Tegaderm for wounds. Okay. So sometimes it'll stick well, sometimes it doesn't, but you can at least see through it, right?
Yeah, so you can see what's going on.
But it just doesn't stick super good, especially if it's wet. So that's why you have to dry around with sterile. Okay. So that would be a good one if I just had a very small wound. Yes, but they're tiny. Yes. And they don't, let me see if this one does. No, it's the same. But you know, like the edges don't look like this, right? The edges. Have you used one of these?
We did when we had to do our ID.
So the edges, yes, you can see like it's flimsy. First of all, you have to put it on first. You have to do it very slowly. But yeah, but I was trying to pull it off so you can see, like, I mean, yes, it is sticky once it's on the patient, but the edges aren't real great. So that's why I just don't love these. Yes, especially if the patient has any type of moisture, if they're sweating or anything, it's not gonna stay. Then this one is Duoderm. This is actually an extra thin Duoderm.
Okay.
That was the one that we were talking about, the fake skin that they can use. So you can actually like feel that. I love Duoderm. I think it is fantastic.
It feels like
you sure? So it's very sticky. It is stretchy, so it moves with your patient. Okay. Okay. If you think of it, yell it. You can cut it. So obviously it's not going to go like this. You can cut it into different shapes, right? And and you just put it on here and then you tape anything you need on top of this. And this can stay for weeks at a time.
And that is the Duoderm.
That's Duoderm. Uh-huh.
Oh, that's pretty cool.
Okay.
Thank you.
Yeah.
See, it helps when I can actually
see it.
Yeah.
And then I pulled 2 different types of the barrier, skin barrier. So this is one that you could use. And this one actually comes like this. It's wet. Don't touch it because it's very sticky. But it can come like this and you can use it. It's a barrier film. You can't see it with your eyes.
Wait a second. You put that
on your patient.
Okay.
So I'll do it on me because I'm on me. Okay. You would do it like this and see it goes on. It goes on liquid. Okay. And it will dry and it will become, it's kind of like a glue. Because when it dries, it forms this barrier. So anything that goes on my skin is just going to come off of the skin. Okay.
Wait, okay. So
So it looks like this.
And that just like it protects the skin.
Yeah, because anything that gets on the skin now is on the barrier rather than being on my actual skin.
Over that barrier or not?
Nope.
No.
I mean, you can put tape over it if you want to, but it doesn't matter. That's not the purpose. You can feel it.
Yeah. Okay. And then so nothing gets into the skin.
Right. So it just forms a barrier so that way that moisture or whatever doesn't get into the skin. Yeah, we use this a lot. Like the reason why I have it is this was I used for Emmy's ostomy. So I use the skin barrier around the stomas. Okay. So that way when poop does come out of it, it looks like it's getting on her skin, but it's not. Okay. It's actually on the barrier. Okay. And then the second way that it comes looks like this. Like a little foam alcohol pad. And you're going to do it the same way. You're going to rub it onto the skin and it's going to dry. Okay.
And that will form a barrier?
It smells horrible. Yeah, that's it. And you can't see it really with your eyes. No. Okay. But feel right here on my skin and then feel on the barrier. It's a very subtle difference. Yeah. But it will not irritate the skin.
Will not. Okay.
So, and they come different ways too, but those are the two most common ways you're going to see them. Okay. Wow. So that's the barrier that you want to put on. Okay. That does not go in the wound. Right? Right. That just goes around kind of the area.
So you would put that on the outside.
Yeah, because if it's draining, it's dripping, like you don't want it to sit on intact skin. Yeah. Okay. So use skin protectant around the wound. It would burn like all holy hell. They were going to scream at you. Yes, they will yell at you and curse you. And yes, it does burn pretty bad. Okay. All right. Any fever in a patient with a wound needs to be reported because I don't know where that fever is coming from. Now, if they're immobile, I mean, they could have had a pneumonia. There's lots of different things they could have had. But if they have no other symptoms, fever and a wound, I'm going to be like, oh, no, that wound may be getting infected. So I need to report that. Remember, in nursing school, they do not have a fever. Yes, if they have a giant wound or a pressure ulcer and they have fever with no other symptoms, you do need to contact. Yes. I mean, it could be a UTI, it could be pneumonia, but it doesn't matter. The point is, it could also be a wound infection. Remember, in nursing school, it's not a fever until it's over 100.4. Okay. Anything below that is not considered a fever. Okay. 100.4. Right. Okay. So if they say your patient had 99.8 temp, okay, good, document. That's it, right? Okay. All right, and then they have a rule called red, yellow, black. Okay. Oh, yeah. Okay. So if the wound is red, yay, right? There's granulation tissue, it's healing. That's awesome, right? Okay. So we just clean it and use a moist dressing, right? That's all we do because it's red and it's happy and it's healing. So leave it alone. Okay. Just cover it? Yeah. Okay. And then if there's moist dressing. Okay. So if it's dry, we use a moist dressing. If it's wet, we use a dry dressing.
So that would be dry?
If yes, most of the time it's not weepy. If it's weepy, then something else is going on. Yeah, granulation tissue is pretty dry. No, it's not wet. If it's red and wet, that's probably inflammation. Okay. Yeah, yeah. Does that make sense? Okay. Yes. And then if it is yellow, that is usually an exudate. Yeah. Now the exudate sometimes has that sloppy kind of, sometimes they'll tell you, hey, clean that off because it's junky stuff. And sometimes they'll say, just leave it intact and put a dressing on it. But a lot of times they'll say, just go ahead and irrigate whatever the slough is at the top, clean it, and then you can put a dressing on it if you want to. But yellow just means there's usually exudate, right? And I think we had a picture of that earlier. Okay. All right. And then black. So black is, that's necrotic. You got to debride it. They need surgery and you need a wound specialist to help you heal it. Yeah. Okay. Like for my daughter, we had the best wound doctor in Houston. He's amazing. He goes around to all of the hospitals. And he used honey in her wound to close it. There's a medical honey, right, that you can use. And the medical honey is called Meta honey, and you pour it into the wound, and the honey. Right into the wound? Yes. Yeah, you pour it right into the wound, and the honey has all these antibacterial properties because you know honey is really good for you, right? It helps with allergies and inflammation and things like that. But you pour it directly, and it comes as also little wipes. It comes in lots of different ways. But yeah, we had a tube of it, and we would put it into the wound, and it would just eat all of the yucky stuff that wasn't supposed to be in there, and then it just kind of heals it step by step. So it would just help it get rid of that stuff. And it also came as a mesh. Actually, I have that too. I can show it to you. I still have some of that. It's really impressive. Hold on. Okay. So these are examples of the Meta honey. Let me open a small one first.
So that's Meta honey.
So it looks like this. I know it looks super gross.
And
And you
you
can cut
cut
off
that?
pieces. Because her I mean, she was a newborn.
So
So
it's
her ostomy
tiny.
was this big. So we would have to cut this off and put it right between the two stomas. And this is saturated. It is a dressing. It's got calcium in it too. But it is saturated with a
So you
medical
just cut
grade
that
honey.
and you just put that in?
Yes, you cut it and you
Whoa.
put it inside the wound. Isn't that amazing? I know, it's so cool.
Wow.
But it still took 30 days for it to close. So once somebody dehisses, like it takes a long time to heal it back.
No matter what.
Plus it was an ostomy, right?
Yeah.
So there was poop sitting in it. So
Yeah.
that didn't do us any favors either,
Right,
you know?
right.
So we had to get really creative with how we packed hers. Okay. She made it. She's doing just fine.
That's good.
All right. Let's see.
Not what you're expecting, though.
No, it's not what I was expecting. I was pissed. Let me see what I brought you. Oh, that's all right.
But you know what? She doesn't know any different, right?
No, and she didn't even know what happened to her until she was like 3, because all the
Yeah.
surgeries were before she was a year,
Yeah.
so she didn't remember any of them.
Yeah.
I mean, she's got scars, obviously. She has a
Right,
big scar
right.
up her back, then she has one in her belly.
Yeah.
But yeah, she would know. All right, clean at least 2 inches below or beyond the wound margins. I told you that, and then apply the dressing at least 1 inch beyond the wound margins. So you want to clean this big, and then have the dressing this big.
Oh,
right?
Tulsa pads are the ones I was thinking of.
Oh, the non-adherent stick, the non-stick.
So those don't stick.
No, one side doesn't stick. So you have like if you have a wound that has exudate,
Are they like the silver?
they're white.
They're white.
Let me see if I have one. I think I might have one over there. Let me see. Oh, I know, it's really cool. All right, so back to the template. So one side is non-adherent, so it's basically like it has a shiny side, and that's what goes to your patient. Now there is a little because that's the non-adherent pad.
Yeah.
So they basically took a non-adherent pad and stuck it around tape like this.
Oh, okay.
So it will stick to your patient, but not in the wound area, right? It just tapes around. Right. Well, it has its own sticky. Yeah, so you can stick it. If it doesn't, some of them are stickless. You can put tape, but you just got to be careful what tape you use because it can be painful. Yeah, because you can't put tape all the way across the back because the whole purpose is for it to be non-adherent.
I see. So you really just need to do the edges.
Yeah.
Right. Okay.
Yeah, just do the edges. Okay.
Okay.
All right. If there is, this is just a reminder, if there's dehiscence or evisceration, that's an emergency, but you stay with your patient because how scary if you left and then their like organs are hanging out. So if they ever say, and they'll do this to you in nursing school, right? They'll say, what's the first thing you do? And you'll see, call the physician. So automatically you want to pick it because you know you have to. But then answer D will be stay with the patient because you didn't read far enough down.
Yeah.
You didn't pick that. So the first thing is like, don't panic. Okay, everything's fine. These are just your intestines. And then you take this big moist towel and put it over there and you're going to put them in low Fowlers, right? And be like, it's fine. Everything's fine. And then you're going to ask them to press the call light. Okay. And then get some of your friends in there. Okay. And do not leave them alone because it's scary.
Yeah.
Okay. All right. No, other than on Emmy, I didn't see it, but her entire intestines didn't come out, right?
Yeah.
It just broke open between the two stomas. But when you look, I mean, you could see down to the fascia. It broke down deep. That's what took us forever to heal it. But no, I've never seen somebody's guts come out, and I'm not interested. Thank you. Yeah. No, thanks.
Drains.
Yes.
I did see the JP drain. I did see that.
Yes, that happens a lot. You'll see in the nursing homes. So wound drainage. So I picked out the 3 most common, I think 3. Yeah, 3 most common types you'll see.
These are the types that they had mentioned.
Yes. So, and there's pictures of them here. So here's the Jackson Pratt. And then you do have a Penrose drain. I did not write about. All it is a flexible tube that sticks in there. It's not connected to literally anything.
What do you mean? It's not connected. So where does
it just drains to gravity. I'll show you what it looks like. So it sticks inside a wound and then it just drains like whatever comes out. And then you have the outside. Well, I worked PD, so we put the outside in a diaper so we could collect the drainage. And you can do that for older people too. Or sometimes I'll wrap it in a sanitary pad. Like,
wait, okay, I have to see it.
Okay. Hold on. Because it just drains to nothing. So this is what the actual tube looks. Literally, it's like a little flexible tube.
Oh.
Yeah.
And you stick the one end of it
inside the wound. Yeah, I'll show you what that looks like.
And how do you keep it in the?
It's sutured. So they stitch it inside.
Okay, that's what I was wondering. How does the tube stay there?
Okay, this is a super gross picture. Okay, so okay. But this guy, from what I'm seeing, he was burned pretty severely. And so they put a Penrose in his chest. Okay, and then you see it just drains to gravity. Now, a lot of times we'll put a diaper, like a teeny tiny diaper, to collect the drainage, right? Because you have to weigh it, or a sanitary pad or something to like kind of collect that drain because it just goes to.
So you
No,
put
because it's not draining a lot. It's just like,
yeah.
hey, let's put it in there because
Okay.
it's an inflammatory process. A lot of
Yeah.
fluid is going to be brought to the area.
So it is put in place with sutures. That's I think what I was confused. I was like, how does that thing get
Yeah,
in
they just
there?
suture it in and then
Okay.
they'll,
Okay. Got it.
or even if it's pulled, it's really no big deal. I don't know. All right, but the
Okay.
Jackson Pratt is actually you squeeze, right?
So you have to have it squeezed.
Or it doesn't work.
Right.
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 So it's meant to, like, when you
That's the
squeeze it, it's kind
negative.
of pulling,
It's the
you know.
negative pressure. That's what they call it. Negative.
Well,
Negative pressure.
negative pressure wound therapy is something different. It looks
Oh.
different. But the bulb is squeezed, so it is pulling its own pressure, but it's just not connected to a wall. Okay.
Okay.
So in the Jackson Pratt, it is creating its own pressure. There is a negative pressure wound system, but it is connected to suction in the wall. Okay.
Oh, so negative pressure is
It's like actually suctioning from the wall.
Oh,
Okay.
okay.
That one's a little more intense. So the Jackson Pratt you see all the time, okay? But when you empty it, it has to be sterile technique because it's inside a wound, right? Remember,
Yeah.
inside the wound is
Clean.
sterile.
Yeah.
Yes. Okay. So when you're ready to empty it, you just pull off the cap, you
Yeah.
pour it into like a little container because it's not going to drain a ton. If it's draining a ton, they wouldn't have a Jackson Pratt because they
Okay,
look
yeah.
like a little tiny grenade. Have you seen
Yeah.
them? They're
Yeah.
super small.
Yeah.
So it's only for like a very small amount of drainage.
Yeah.
Okay. So you're going to pull off the cap and this needs to be sterile, obviously, because it's inside the wound. Okay. And then you dump it into the chamber, right? Whatever you're collecting. And then you need to squeeze it again, put the cap on so that it will stay compressed. And then you're done.
Squeeze it, yeah, after you empty it.
And then you measure it and whatever,
Right.
you know, the color or what have you.
Right.
And that's it. That's all you have to do for it, really. Now, the big things that I did want you to know about it, though, are you will clean the suture site with just normal saline. So remember, if any solution touches the skin, it really needs to be normal saline.
Yeah.
Okay. Emptying the drainage is sterile. Okay. But if you're putting a dressing on the outside, that's just clean, right? Because you're not inside the wound.
Okay.
Okay.
It's just on the outside.
Yep. And then drain it, Q4, and document the output. It does need to go on your INO sheet because it is output. Okay. If the patient accidentally pulls the drain out, then you're going to be like, oh, let me look at it first, right? Because there's a hole. So the first thing you're going to do is assess the site. Then you cover it with a sterile gauze because there is a hole in the wound. And then you need to call the doctor. It's not an emergency, but I'd be like, hey, I just want to let you know they pulled out their Jackson Pratt. What do you want to do? And sometimes they'll say like, hey, we need to go put it back in, or they'll be like, that's fine. Just tell me if there's any extra drainage from the site.
Oh, okay.
Okay. So it's not an emergency, but I am going to call.
Okay.
If the patient is ambulatory and they want to move, remember we are going to clip the drain to their gown so that way they can actually move because you don't want it hanging down.
Yeah.
And yeah,
yeah,
that's disgusting.
Like
exactly. We don't want that. Okay. So that's the Jackson Pratt. Make sense?
Yes. Yes.
All right.
Yes.
Then there's the Hemovac. So the Hemovac
Yes.
is also going to work on that same pressure system, but it looks like a little accordion,
Yes.
right? And you squeeze it.
Yes.
Okay.
She actually showed us one of those.
Oh, cool.
Yes.
Okay.
Yeah.
But make sure that before you are going to dump it or whatever.
So that's squeezed.
Mhm.
You squeeze it first.
Yes.
Right.
Same thing as you do Jackson Pratt.
So it's a similar,
Yes, it's almost exactly the same thing. But a
Okay.
Hemovac usually is eliminating blood. It's trying to bring blood flow to the area.
Oh,
Okay. So Jackson Pratt is usually, I mean, you'll have all kinds of drainage in there. It may be serous, serosanguinum, you could have anything depending on what level of healing that they're in. The purpose of the Hemovac is to get, you're basically pulling to get blood flow to that area because it has white blood cells and it has leukocytes, it has macrophages, it has things in there. So you're trying to pull blood flow to that area. Okay. So you are still going to use sterile technique when you're emptying it because it's inside the wound, right? And you're going to do it the exact same way. Sterile technique, pull off the cap, empty it, compress the device, replace the cap, right? And then you're going to write down the color and the amount and all of that of the drainage, right? If they're ambulating, attach it to their gown. Check the discharge every 4 hours, right? We're going to change it every 4 hours if we need to. But you need to empty it when it's at least 2/3 full because if it gets too full, it's not going to suction well, right? Because it's too full. Okay. And then the dressing needs to be checked every shift. And if you're just changing the dressing, remember that's clean, right? Because you're not inside the wound. Okay. You're just like putting a new thing. Okay. Then the third one is a negative pressure wound therapy. I actually do need to show this to you. It is a suction that you connect to the entire wound. Okay. Let me show you to the whole thing. I'll show you.
Well, those must be pretty big wounds.
They could be, yes. But you're trying to like suction a bunch of stuff like to the area. Okay, you're trying to get it to heal. This is a healing modality for your patient. Okay. Let's see. Okay, so here's one on the leg. Okay. And I'll explain to you how to do it, but you're basically, it's connected, it's a suction that's connected to the wall. I'll show it over really quick.
Oh,
And it will help to bring fluid to that area to heal.
okay.
Okay, let me show you one that's not on the leg. A lot of these are on the leg because you don't get good blood flow to the leg. Like if you have diabetes or peripheral artery disease, they may not be healing well because there's not enough blood flow down there. But let me see if I can find one that's not on the, no, all these are on the leg. Let's see. I've seen them on the back before, but let me, no, I would say almost all of these are on the leg, but here's one on the inside of the leg, right?
Oh,
So
okay.
it's
And then
basically
where?
suctioning.
Okay.
It connects to the
Oh, and
wall.
that's the little thing right there. That container right there is, what is that?
No, this is actually, well, that might be a portable suction, but I think that's part of the bed. But there, it does
Oh,
connect to a suction. Okay. And each one of them is going to look different because there's different healing
so it's
modalities,
connected to a
obviously.
suction, but is
It's
that's
connected
not
to a suction, or it can also, you can connect it to a bedside suction too.
what about
There's
the
some that would be portable. So like if you have to take the patient to MRI or CT or something like that, you can have one that can actually go in the bed with the patient. Just like you could connect the patient to the wall with oxygen, or you can put them on a portable tank, right? If we need to travel,
Okay.
right?
Okay.
So this one is a portable machine that you could put in the bed with the patient.
Oh God.
Okay.
Okay.
If we need to do that, hold on, let me greet this young lady really quick and then we'll finish up. All right, so it could be connected to the wall or it could be portable for your patient. Okay. So when you're changing the dressing, you first have to turn it off, obviously, because you don't want it suctioning while you're, turn it off, and then you take off the whole old dressing because we want to look at the whole wound. I need to assess the wound. I need to clean it, right? So you take the whole thing off. Okay. You're going to clean it or irrigate it. That's sterile. Yes. Yeah. So you would need to change everything by that point and it's sterile. Then dry around the wound. Remember, not inside the wound, but around the wound with sterile gauze. We've talked about that before. Apply a skin barrier. I showed you two of those. Okay. And then you need to.
Is it always a skin barrier when you're doing the negative
I would
pressure?
say most of the time, just because it gets real sweaty underneath those dressings. So you want to maintain skin integrity. Okay. Then you're going to measure and cut whatever you fill the wound with, because these wounds are usually kind of crater wounds, right? If I just put a dressing like a tegaderm across that, it won't suction. So I have to fill it with something. So you can either fill it with, there's a foam dressing, there's gauze, or there's also a silicone dressing that you can use. So you're going to pack inside the wound. So your wound looks like this, right? And then you're going to pack it with something. Then you put a big giant, looks like a big giant tegaderm across it. Then you attach the suction to that whole thing. So the, okay, across the whole thing, but it has to have something to suction. It can't be empty. So that's why we fill it. Okay. So you're going to cover it with a giant tegaderm, and then you apply the connector pad and the tubing port. That's the part that's going to actually suction it. Okay. And then to the patient. Yeah. Yeah. And then that's going to suction the whole thing. Okay. So you've got the wound, you've got it filled, you've got the giant tegaderm like this, and then you got the big sucker. And it's trying to suction things to the wound so that way you can get blood flow to the wound and heal it. So it is a healing modality. No, it's not suctioning stuff out. It's suctioning to your, like suctioning from within to your skin.
Okay, so that's different than like the JP because you're actually getting
yes. So JP and Hemovac, you're trying to like eliminate any drainage that's inside of there. The negative pressure, because it's called wound therapy. It's meant to be therapy, right? It's meant to pull blood flow from inside your leg to the surface of your leg so that it can heal. Okay. That's the difference. Yes. Jackson Pratt and Jackson Pratt will usually eliminate either purulent drainage or just junk that's in there, right? The Hemovac is meant to kind of bring blood flow to the area as well, but it will drain. Like it'll pull stuff like out. Yes. The negative pressure wound therapy is meant to pull enough blood flow to the surface so that you can get healing. Okay. And then if you see the dressing shrink up, then that means it's sealing, right? Because you can tell that it's suctioning. Okay. And then that dressing has to be changed every 48 to 72 hours. Yes. Because at that point it's probably going to get gross. But the other ones you check every like 4 hours. Yeah. Yeah. Make sense? Yes. Okay. Questions on the drainage system? All right. We're going to talk about wound healing. This is very boring. So I'm just going to get through it really quickly. Okay. Factors that affect wound healing. It is very important your patient gets the nutrition that it needs in order to heal these wounds. Okay. So what I did here was I gave y'all different things that your patient has to have in order to wound heal and then what those things do. So vitamin K helps you with clotting. Zinc is a antioxidant. What will that antioxidant help me with? Fight free radicals. Okay. And it helps with cell proliferation, which means to build new cells, right? Your patient needs protein when they're wound healing because that builds all of our healthy cells, right? Carbs help to build white blood cells. Vitamin C helps to make collagen. What's collagen?
That's like that.
Or like you're supposed to, like have it, keeps your skin elastic. Keeps your skin elastic. No, that's the other way. Vitamin A helps with epithelialization, so it builds new layers of skin. Okay. B vitamins. All B vitamins help make new healthy cells. So you got to have your B vitamins. Okay. Something else that impacts wound healing is your blood flow. How do you heal a wound? Your body says something's wrong and it vasodilates and it brings blood flow. Well, what if you're a patient that has peripheral artery disease and you have a cold dead leg? Can you get blood flow down there? That's why patients with diabetes and peripheral artery disease get big ulcers on their legs and they don't heal because they can't get blood flow down there. Do you understand? Number 3, things that affect wound healing is your immune system. If you have a crappy immune system, you're probably not going to heal very well because you can't get good blood flow down there, right? Number 4, obviously, is aging. Y'all know over time that the thymus decreases in size. That's often on your exam. The thymus decreases in size. What's the job of the thymus?
Like the
Yeah, it helps to make white blood cells. And so as you age, you kind of lose the thymus function, and so your immune system will decrease. Okay? There are 4 different steps to wound healing, kind of like we went through the steps of getting sick, right? Mm-hmm. This is what we're doing. So you hurt yourself in some kind of way. Your body immediately says, something is wrong. And so hemostasis is stage 1. Its job is to make sure you don't bleed to death, okay? Because it knows that there's something wrong, but it doesn't really know what, right? But can't you bleed to death way faster than you could die from an infection? Mm-hmm. So it immediately is going to vasoconstrict. Immediately, as soon as you do something to yourself, it's going to be like, something is wrong at first. Okay, this hasn't happened yet. Okay. All it knows is she cut something or something happened. So it's going to immediately vasoconstrict just to bring platelets in case it was a bleed. If it realizes, okay, that ain't really what's happening. Okay. So then it's going to go into our normal inflammatory response. You see stage 2 is inflammation. So your body's going to say, something is wrong. Vasodilate, increase, blah, blah, blah. Do you understand? Okay. It's also going to bring white blood cells out. We did 4 steps to white blood cell activation. You remember that? That's where that fits in. You're also going to bring out neutrophils. What's the job of the neutrophils? What do they kill? Bacteria. First defense, bacteria. Macrophages, what do? They eat. Phagocytes, what do? Eat. And then they're going to, after they ate everything and everything's all dead and gone, okay, then we got to make growth factors. So that's included in the inflammatory response. Then we go into stage 3, which is called proliferation. What does it mean to proliferate something? Let's build it back up, right? And so you may produce something called fibroblasts. Anytime you see blast, that means to build, okay? So you're building new layers of fibrin. You're going to increase your collagen, growth factors. Do y'all know what granulation tissue is? It looks freaking disgusting and nasty. It is a very vascular tissue, okay? I'm going to show it to you. When you look at it for the first time, if you don't know what it is, you're going to think it's infected. But it's actually very, it's tissue, new tissue that's being built that has a ton of blood flow in it to kind of help your tissue regrow, okay? But like I said, it's going to look nasty if you don't know what you're looking for. This is granulation tissue. It is new tissue. It is highly vascular. You can see it's very red. Okay. So its job is to bring a bunch of blood flow to the area to build new tissue. Do you understand? Okay.
Would that happen if you have a tissue, a graft or something like that?
A graft? Yes, you will have to grow back that skin. I mean, it will adhere to your skin, but you still have to make new layers. Okay. So yes, absolutely. Epithelialization. What does that mean? What is epithelial? Skin. So it's building new skin layers. Okay. Then it's going to form a scab. You with? Okay. Last stage is remodeling. We want to make sure it doesn't look really crappy. Okay. So it's going to use collagen to make fibroblast to make your scar. Do we understand? Finish right on time.